Hi, good evening everyone. Good evening. I welcome you all to this very exciting session for the day, that is our module 2 of the Resident Masterclass. And today we are going to discuss a purely theoretical topic, that is newer modes of ventilation. Now, why do I say that it's a purely theoretical topic? Is because we have designed these newer modes of ventilation thinking that it is going to change the patient outcome, or it is going to improve, or it is going to decrease the risk of complications that are associated with mechanical ventilation. But either studies have not been able to prove any superiority of these newer modes of ventilation over the conventional modes of ventilation, or they have down and out been useless. But it forms a very important part of the recent advances in the exams that we come across. So in theory and sometimes in practical, they might just pop up a question, okay, do you know NAVA, or do you know APRV, or do you know inverse ratio ventilation and stuff like that. So we are going to discuss them, and I have divided them into very amazing ways. I have just tried to compare similar modes of ventilation with each other. So the problem that happens when we are discussing a topic like newer modes of ventilation is that we don't use it. And because we don't use it, therefore our perception of things is not very, what you can say, coherent when we are writing, because we are not using it. But if I tell you volume control ventilation, you will be able to write from whatever you do every day. You'll set a tidal volume, you seal a peak inspiratory pressure, you'll look at the PEEP, you look at inspiratory expiratory ratio and stuff like that. So even if you have not read it properly in a conventional mode of ventilation, because you use that mode of ventilation, you will be able to very correctly able to at least write down about it something. But in newer modes of ventilation, the writing part becomes very difficult because the terminologies are very unique, because we don't use them. These are all research mode of ventilations, because even when your ventilator has one of these modes, you are never really taught how to use it because nobody really uses it. So what I have done is I have tried to summarize the gist of it and then make it in a way that you are able to reproduce that in the exam, because it's a theoretical topic. Now people can ask ki sir isme aur bata do, usme aur bata do, what does this mean, what does that mean? Yes, we can go into the details of everything, but then ultimately it would not make a difference, because you won't be able to put all those things back into the theory. So for that purpose, I am wanting you to understand my concept here. I've tried to summarize it in minimum possible words. That is the whole idea, because I could have made a presentation with every detail of the mode, and then you would have ultimately not remembered anything. So we divide modes of ventilation into conventional modes, dual control modes, and biphasic pressure model modes. Conventional is what we have already discussed, that is completely controlled, that is pressure controlled ventilation, volume controlled ventilation. Then you have partially controlled, where you have assist controlled ventilation. I told you the difference between a controlled mechanical ventilation CMV and assist control is the patient trigger. SIMV, which is synchronized intermittent mandatory ventilation, which we discussed in detail, that can either be pressure control, it can be volume control, it can be SIMV pressure control with spontaneous breaths, can be pressure supported. So it's a combination of lot of things. And then completely spontaneous modes like pressure support ventilation and continuous positive airway pressure, or CPAP. All right. This is something that we have already discussed in detail and finished. Then you have the newer modes of ventilation, which can be dual control mode of ventilation and biphasic model. Now the dual control mode of ventilation has a very important component called as closed loop ventilation. What is a closed loop ventilation? So closed loop ventilation means that ventilation or ventilator will supply the breath to the patient. This is normally what happens. Ventilator, you preset some values that you want to give these values to the patient, and the ventilator delivers this breath to the patient. Closed loop means the patient will then send some information to the ventilator based on which the breath will change its characteristics. Based on the information by the ventilator. So it becomes a closed loop. So it is a feedback cycle that the ventilator will adjust according to the feedback given by the patient, which doesn't happen here. Which doesn't happen here. In conventional modes of ventilation, usually there is no closed feedback. What happens is whatever you set, and whatever that can be, whatever you set is what the ventilator follows. Doesn't really matter what the patient is giving. Suppose this changing respiratory dynamics of the patient. Usually the ventilator doesn't take into consideration and you get a lot of patient ventilator asynchrony. To avoid that, we started thinking, okay, what can we do to make this process easier? So we started making dual modes of ventilation, which combines the advantages of two different modes in one mode only. Now they are divided into intra-breath variation and inter-breath variation. Intra-breath, imagine the ventilator senses the change in the characteristic of the patient while the ventilator is ventilating and changes the breath characteristic, that is volume assured pressure support and proportional assist ventilation. These are intra-breath variation. Inside one breath, the ventilator adjusts. Most of the dual modes that we commonly use are inter-breath variation, that is they take feedback from few breaths, 2 to 3 breaths, and then changes the ventilator characteristic accordingly. These are always pressure limited. They are always pressure limited because the whole idea is that when you use a volume limited ventilation, there is always a risk of over distension, there is a risk of barotrauma, there is a risk of pneumothorax, there is risk of lot of complications that are associated with volume mode. So the whole idea of a dual mode is to combine the advantages of a volume assured delivery with a pressure limited safety. So they are always pressure limited, which can then be time cycled or flow cycled. Time cycle becomes more of a controlled mode of ventilation where the cycling happens based on time, which the most common mode, which I'm sure a lot of you have seen in your anesthesia ventilators as well in the OT, is PRVC, that is pressure regulated volume control, something that is very commonly these days. Then you have ASV, that is adaptive support ventilation, and then you have something called as auto mode. While flow cycled is when the decrease in flow cycles from expiration to inspiration. Inspiration to expiration, we have volume support ventilation, that is VSV, volume support ventilation. You might feel that, okay, I have heard this term, pressure support ventilation, PSV, usko change kar diya, volume support ventilation. You'll realize these are all some mixtures that have been done just to achieve the final target. And then you have biphasic pressure models like BiPAP, which we have already discussed, but we'll discuss it again. APRV, which is very interesting mode, which is still something that we use in acute lung injury or ARDS, that is airway pressure release ventilation and high frequency oscillatory ventilation. I'm putting in biphasic, but we are going to discuss high frequency ventilation later on because it has a lot of criteria and we are not going to completely discuss these criteria here. Okay. So with this, we'll start with the first, that is the pressure regulated volume control. Pressure regulated volume control, also very fondly called as PRVC. Now again, I will tell you one thing, even if you do not remember the exact details of any mode of ventilation, just look at the terminology. See, the terminologies are not meant for you. The terminologies are meant for the people who are using the ventilators in daily life, and therefore the companies make the names so that they can easily identify that what would it be based on the name. So pressure regulated volume control. So ultimately the idea is to achieve a set tidal volume, but to make sure that you do not cross a particular set pressure. So it is pressure limited volume control. Other names are auto flow, volume guarantee, adaptive pressure ventilation, and variable pressure control. These other names can sometimes come up, but usually it is the standard terminology that comes into use, that is PRVC. Okay, let's look at the concept. This is the part that you have to reproduce in the exam, the concept. What it does is it takes the benefits of decelerating flow pattern of pressure control decelerating flow pattern of pressure control with safety of volume guarantee. Because ultimately you have to achieve a particular set minute ventilation that can only happen when you have an adequate tidal volume. So the concept is to take the benefits of a decelerating flow pattern, which is a pathognomic, which is a classic feature of a pressure controlled ventilation. Okay. So what does ventilator does is the ventilator attempts to achieve set tidal volume using pressure controlled gas delivery. And we know how a pressure controlled delivery is. It initially has a very high flow and then there is a decelerating flow pattern, keeping the airway pressure lowest. This is the crux of it. It is making sure that your patient receives adequate tidal volume, keeping the minimum airway pressure. And that is where the safety lies, minimum airway pressure. All right. How does it do it? Let's look at the mechanism. So the ventilator first gives a test breath. Usually, whatever you set two things in it. You first set a tidal volume that you want to achieve and you set a maximum pressure that the patient can have. Okay. But ventilator, what it does is it first gives a test breath, that is a breath at minimum pressure level. Usually 5 to 10 centimeters of water. This is to check for the resistance and compliance of the breathing system with an inspiratory hold. So initially you will always find tidal volumes are 250, 300 and you always see an inspiratory hold. This is to calculate the patient's compliance. Then what it does is the ventilator calculates plateau pressure. To achieve a set tidal volume. Then it will give few breaths. To achieve the set tidal volume. And then the final breath will be delivered. So that is how it works. It starts with a test breath, which is a very small breath with an inspiratory hold. This calculates the compliance. Based on that, there will be calculation of plateau pressure that will be required to achieve the set tidal volume. Then again, the ventilator tries to only deliver few breaths to achieve the set tidal volume. And then when it finally understands what the patient is, then gives the final breath. So this final breath is actually a volume targeted with pressure adjust to reach final tidal volume. It is a volume targeted with pressure adjust. And it will keep on taking the feedback from the patient every 2 to 3 breaths. It will keep on doing that. So what happens is usually this is how it looks. Initially you have a test breath which will measure the tidal volume compared to set tidal volume. If the patient is receiving more tidal volume than the set tidal volume, it will decrease inspiratory pressure. If it is delivering less than the set tidal volume, increase inspiratory pressure. If it is the same inspiratory pressure. What is important is that it always changes the pressure in 1 to 3 centimeters of water, not more than that. 1 to 3 centimeters of water is what it adjusts, and whatever is the highest level that you set, the ventilator is usually trying to keep it 5 centimeters below that highest level. Okay? So this is the initial ventilator setting. This is not something that you can reproduce, but this is something that is for your understanding. Now, respiratory rate is physiological for the age. If patient is spontaneous respiratory rate is less than the set rate, ventilator gives additional control breaths to make up the difference. If it is more, then no control breaths. Target tidal volume is usually excuse me, 6 to 8 ml per kg predicted body weight. We have discussed all these things in the last session. Then you set the upper pressure limit, and the ventilator will always deliver 5 centimeters below the upper pressure limit, which is usually set between 35 to 40 to ensure it is safe. Then initially 100% FiO2, inspiratory expiratory ratio usually 1:2, PEEP 5 to 10, and rise time is 5% of inspiratory time, which is usually satisfactory in how much time the pressure should rise. So you do this, and then again the same thing will happen. First there will be a test breath. Based on this test breath, it will measure the tidal volume. If the tidal volume is more, decrease pressure. If it is less, increase pressure. Always increase in the factor of 1 to 2 centimeters of water. So it takes 2 to 3 breaths to adjust and then finally deliver. This is pressure regulated volume control. You can very easily understand what is happening. You are basically taking the disadvantages of the volume control, the disadvantages of pressure control, and you are combining both to eliminate the disadvantages. If we look at the advantages and disadvantages, the biggest advantage is that it guarantees tidal volume, which is very important because your minute ventilation, your CO2 elimination is based on your tidal volume. And if you keep on having a fluctuating tidal volume, you can never really be sure how much CO2 are you eliminating. Minimizing risk of barotrauma, because you will never go beyond the set tidal volume. Even if the changing characteristic of the respiratory compliance, the pressure that is being given by the ventilator will also keep on changing. Okay, and decelerating flow pattern. And we know decelerating flow pattern is more physiological. Decelerating flow pattern is more physiological, so it improves oxygenation. Disadvantage is obviously variable tidal volume. So it can have an increase because the ventilator will keep on adjusting. So the tidal volume will never be at one level. It will keep on changing. And it has been shown to not decrease the work of breathing. Ultimately, weaning is not very easy with this mode. Weaning is not very easy with this mode. Doesn't decrease the work of breathing, right? So it's usually comes as a short note, but it is also something that will be asked to you in the Viva, because this is a mode of ventilation that we commonly have in our anesthesia ventilators. Okay. So this is PRVC. This is pressure regulated volume control, PRVC. Okay. Next we come to volume support ventilation, which is a flow cycled mode of ventilation. Volume support, and the name is only telling you pressure support, volume support. What were we doing in pressure support? Whatever the spontaneous mode of, it is a spontaneous mode of ventilation. In pressure support ventilation, the ventilator was augmenting the pressure that you have set, which was above the pressure generated by the patient. So suppose the pressure generated by the patient is 7 centimeters of water, you have set a pressure support of 5, it will add 5 over 7. Now as the patient keeps on improving its inspiratory pressure, the tidal volume will keep on going up because the ventilator will always add 5 centimeters of pressure. So if it was initially 7, ventilator added 5, 12. Now it become 10 and ventilator will add 5, it will become 15. So the volume will keep on increasing, again the risk of barotrauma. So now here what we have done is we have done a volume support ventilation. So now we have preset a set tidal volume in a spontaneous mode, and now the ventilator only gives the pressure required to achieve that set tidal volume. So first it's a spontaneous mode of ventilation. It is a spontaneous mode. What is the concept here? The ventilator adjusts the inspiratory pressure to ensure lowest possible inspiratory pressure to deliver a set tidal volume. So we have kept tidal volume as our target here, and we try to achieve a set tidal volume, and whatever the minimum pressure that is required to achieve this set tidal volume is what your ventilator will deliver. Now this is something which is very unique in the post-operative period for us, because that is where we are wanting that the patient should just get adequate tidal volume. Thoda patient generate कर रहा है, थोड़ा आपको देना है. What happens with the pressure support is that you are not in control of the ultimate tidal volume, because as the patient will keep on improving, the tidal volume will keep on increasing, because the pressure support ventilation is a simple ventilator mode where it will add to the pressure that the patient is generating. So the indications are post-op recovering patients. From anesthesia. That is when initially you have low tidal volume as the patient's respiratory tone, muscle contraction keeps on increasing. In pressure support, the tidal volume will keep on increasing. Here the tidal volume is set, so the inspiratory pressure given by the ventilator will keep on decreasing. Spontaneously breathing patients who require minimum tidal volume. Asynchronous on ventilator. Somehow your traditional modes of ventilation are not able to synchronize with the patient's respiratory rate. So you give a volume support ventilation and weaning the patients with neuromuscular weakness. So here what is important is that you support the patient's tidal volume so that the patient will keep on breathing, and as the weakness will keep on improving, so will the inspiratory pressure keep on decreasing. So these are certain indications. So ultimately remember कि अगर आप support कर रहे हो volume को, so then it is ultimately important where there is some problem with the neuromuscular recovery, that is usually a post-operative patient or somebody with a neuromuscular weakness. Okay, with a neuromuscular weakness. Let's look at the mechanism. So it's a spontaneous mode with patient triggers the breath. What will happen initially? There will be a test breath that will be at 5 centimeters of water, and then the pressure is increased slowly. Now maximum, इसको ना दूसरे कलर में लिख रहा हूं, max pressure target is usually 5 centimeters below set pressure. So just it will keep on increasing the pressure to achieve adequate tidal volume or preset tidal volume. Now at any point of time, if the patient goes into apnea, then there is a backup mode of PRVC. So the patient will then switch to PRVC. ठीक है? Very simple. When volume support ventilation. I don't think you will ever get confused in volume support. Just remember pressure support and change pressure to volume. Advantages: automatic weaning. You don't have to do anything. As the patient will keep on improving, the ventilator will keep on decreasing the pressure supplied in the breath, and therefore the patient will start weaning off. Okay? Automatic weaning. Disadvantage is that it's a spontaneous mode. It's a spontaneous mode. There is always a possibility of auto peep because of breath stacking, auto peep. And then if there is sudden change in patient, then ventilator can't keep up. Because it needs time to adjust. So if there is sudden change in the pressure, sudden respiratory rate बढ़ गया, sudden respiratory airway resistance बढ़ गया, suddenly compliance कम हो गया, तो the ventilator will not be able to keep up because it will need time to adjust to the breaths. It will need time to adjust to the breaths. All right. So we started with the discussion of newer modes of ventilation. We divided the newer modes into dual modes and bilevel modes. In dual modes, we are doing closed loop ventilation, in which we are doing intra-breath, inter-breath. We are first discussing the common mode, that is inter-breath. We started with a controlled mode, that is PRVC, pressure regulated volume control. And now we have seen its equivalent in spontaneous mode, that is volume support ventilation, right? Now we will look at something which is very, very interesting, both of which are short notes, that is mandatory minute ventilation MMV and adaptive support ventilation. Now here things go interesting. I have taken the most commonly asked modes of ventilation, newer modes, and I have tried to compare them for you so that you know कि क्या difference है दोनों में. ठीक है? Mandatory minute ventilation was the first closed loop ventilation ever used. Closed loop means the patient's feedback change the ventilator, the ventilatory things. That is closed loop mode. What it does is it allows the patient to breathe spontaneously with guaranteed minimum ventilation, minimum minute ventilation by the clinician, whatever the clinician has said. And so here the most important thing is the minute ventilation that ultimately decides the alveolar ventilation, that is oxygenation and the expulsion of CO2. So what this mode does is it allows patient to breathe spontaneously with guaranteed minimum mandatory minute ventilation, which is set by the clinician. How it does it? By two ways. If it is a spontaneous breath, if the patient is taking spontaneous breath, then it will increase the pressure support. If the patient is apneic, then it will supply mandatory breaths. It will supply mandatory breaths. These mandatory breaths will be time triggered and they will be volume controlled. अब जब हम ये बोलते हैं time triggered volume control, now things must be very easy in your brain because you know how these things work, है ना? Time triggered volume control. So it basically assures that the patient receives a minimum mandatory ventilation, that is minimum minute ventilation that you have set. Adaptive support ventilation, the name is only telling you ASV, adaptive support ventilation. Now this is a very new mode of ventilation where everything is done by ventilator. नाम याद रख लेना, adaptive support. So this is the first mode that selects all parameters except PEEP and FiO2. Only two things that you select is PEEP and FiO2. Baki everything it does only. Basically, this is a mandatory minute ventilation plus a adaptive pressure control. It's an adaptive pressure control. So ventilator automatically selects the appropriate tidal volume, frequency for mandatory breaths and appropriate tidal volume for spontaneous breath to achieve a target alveolar ventilation. So what the ventilator does is, ventilator selects tidal volume and respiratory rate for mandatory breaths. And tidal volume for spontaneous breaths to achieve set alveolar ventilation. To achieve set alveolar ventilation. So सब कुछ ही ventilator कर रहा है, तो it is the easiest mode to manage. Actually, what you have to do is nothing, just put in the patient data, that is the age, the gender, and it will calculate the ideal body weight, it will calculate the requirement, you will feed in more data, and then you just have to set the PEEP and FiO2. Okay. Now, what is the advantage of a mandatory minute ventilation is that it reduces long-term complication of mechanical ventilation, because it is letting the patient breathe. So it is promoting spontaneous ventilation. The advantage of adaptive support ventilation, सब कुछ ही ventilator कर रहा है, तो you get a decelerating flow pattern. You get a decelerating flow pattern which improves gas exchange. Decreased work of breathing and automatic weaning is possible. Decreased work of breathing and automatic weaning is possible. So I told you it is basically both the modes are same. Both the modes are same. Only thing is that adaptive support ventilation takes it one step ahead. In mandatory minute ventilation, the only feedback that the ventilator gets is, okay, whatever you have set, but you have to set the tidal volume, you have to set the respiratory rate, and then you have to set the minute ventilation. Here you don't have to do anything. Everything is done by the ventilator. It only decides what it wants to give. It just makes sure that the patient receives what you intend for the patient to receive. Okay. See, this is the difference between, I'll tell you. Okay, I'll show it to you later. How adaptive support ventilation is different from mandatory minute ventilation. I'll show you the graph later. Okay. Now, so we have now discussed mandatory minute ventilation, which was the first closed loop ventilation mode, and we get short note on it. So when you get a short note, you know what to write. First, closed loop ventilation. The concept allows patient to breathe to achieve a adequate minute ventilation by increasing pressure support of spontaneous ventilation. If the patient is apneic, then mandatory breaths, which are time triggered and volume control. Advantages: reduces long-term complication. Adaptive pressure ventilation is simply a higher version of mandatory minute ventilation. Now we will come to the intra-breath variations, intra-breath variation modes. This is intra-breath variation. Here, the ventilator is changing the characteristic of the breath during the breath itself. Intra-breath variation. Okay. The first is volume assured pressure support, VAPS, volume assured pressure support. When I say intra-breath variation, then the character of the breath changes within a breath from pressure control to volume control if minimum tidal volume set is not achieved. Very unique. It will change the characteristic of the breath from pressure control to volume control while the breath is being given. उसको अगर ऐसा लग गया कि अच्छा ये तो tidal volume set नहीं होगा. So the type of breath will make a difference. Type of breath. Patient makes an effort. If the effort are adequate, then pressure support breath is delivered. If the effort is inadequate, then you have a controlled breath that is delivered. And in control breath also you have the option of flow target and volume cycled. Flow target and volume cycled. So inside the breath also you can change the characteristic of the breath. PAV is proportional assist ventilation, also called as proportional pressure support. Also called as proportional pressure support. Now here the ventilator generates the pressure proportional to patient's effort. Again, it's a closed loop ventilation mode where the ventilator generates pressure proportional to patient efforts. Proportional to patient efforts. This is a spontaneous mode of ventilation. It's a spontaneous mode of ventilation. What the operator does is it sets the percentage of support that the operator wants the ventilator to give to the patient. And then it will sense the inspiratory effort of the patient and deliver that particular support to the patient. The support can be 5% to 95%. Operator sets percentage of support to be delivered by the ventilator. Percentage of support to be delivered by the ventilator. Let's look at the advantages. Advantages of volume assured pressure support ventilation. Volume assured pressure support. Minimum pressure support to achieve tidal volume. Decreases work of breathing. Decreases the work of breathing. Proportional assist ventilation has never been actually proven to have any superior benefit as compared to other modes, but it was made to theoretically have the effects of decreased work of breathing, improve synchrony, because the ventilator will keep on sensing what the patient's inspiratory efforts are, adapts to patient's needs, decreased need for sedation, decreased need for sedation and improved sleep of the patient. Improved sleep of the patient. Decreased need for sedation and improved sleep. Proportional assist ventilation is just a theoretical ventilator mode. Theoretical ventilator mode. We made VAPs and then we thought we can improve it better. So we made proportional assist ventilation. Okay. They both can change the intra-breath cycle. They can change the characteristic of the breath intra-breath. See, this is what it means. This is the set pressure. This is the inspiratory trigger by the patient, and this is a pressure breath that is given. Now again, there is inspiratory effort. While the patient is achieving this, there is something where it tells that the tidal volume will not be achieved. So it increases and changes to a volume breath. And then this is to achieve the set tidal volume. This is what happens in a volume assured pressure support, which is the intra-breath variation of the mode. Intra-breath variation of the mode. Can you see? ये breath देते देते उसने realize किया कि अब ये मैं नहीं दे पाऊंगा, तो let's do this. ठीक है? This is proportional assist ventilation. Ventilator measures respiratory system characteristics. देखो ये जो blue वाला है ये patient का effort है. If the patient's effort is more, then it gives more breath. So the flow, the pressure, the volume delivered by the ventilator are adjusted proportionally to the patient's effort. More the patient's effort, more is the pressure. Less is the patient effort, less is the pressure. That is proportional assist ventilation. Proportional assist ventilation. So it helps decrease the work of breathing by the patient. It helps decrease the work of breathing by the patient. Okay. It helps decrease the work of breathing by the patient. So now we have done intra-breath variation. I told you dual modes of ventilation are intra-breath, inter-breath. Inter-breath mein two most important is PRVC and volume support ventilation. And then you have adaptive control ventilation. We have one auto mode which we'll discuss later on. So kuch nahi hai, sab kuch is set by the ventilator itself. Intra-breath mein you have volume assured pressure support, which we just discussed, and proportional assist ventilation. Now we'll compare the different modes of ventilation in terms of PRVC, volume support, and volume assured pressure support. This is a very good table. This is a very, very good table. Now only try to understand what is different between the three and what is common. See, what is common is that in all these three modes, set tidal volume is the target for each breath. Set tidal volume is the target for each breath. Set tidal volume is the target for each breath. What is common? Normal cycling may stop inspiration below or above the set tidal volume. Normal cycling occurs at or above the set tidal volume, but in volume support ventilation, cycling starts when there is a drop in flows by 5 to 15%. Why? Because this is a spontaneous mode of ventilation. So in spontaneous mode, remember, it is always the flow that cycles the ventilator. Then in both, what is different is that in volume assured, the character of the breath is changed within the breath from pressure control to volume control, while it doesn't really measure the tidal volume mechanics of the patient. While in pressure regulated volume control and volume support, pressure is used to base the mechanics of the measurements, and tidal volume is used, or pressure mechanics, as constantly as an input. Okay. So remember, the difference lies in intra-breath variation between volume assured pressure support and the character of the breath that can be changed intraoperatively. Intra-breath from pressure control to volume control. Okay. Now we will discuss two modes of ventilation, which are the bi-level modes of ventilation, where we use two different pressures. And these are very, very specifically useful in patients with acute lung injury or ARDS patients. The ventilatory strategies of which we discussed last time. So acute lung injury and ARDS. Okay. Now these are very unique. You know a lot about BiPAP because, again, if you have been to ICU and you have seen an acute exacerbation, acute hypercapnic exacerbation of COPD, then you know that BiPAP is the thing that is going to take the patient out of that exacerbation. You will start with bronchodilators, you will start antibiotics, you will start with BiPAP and the patient will improve over 6 to 8 hours and the requirements of the BiPAP, you actually don't need to intubate somebody who is on acute hypercapnic exacerbation of COPD. That is where the role of BiPAP comes. And BiPAP is a very, very straightforward mode of ventilation, which is also called as biphasic or bi-level positive airway pressure. It is biphasic or bi-level positive airway pressure, while APRV is combining the advantages of a bi-level along with an inverse ratio ventilation. So what is APRV? It is a airway pressure release ventilation. APRV is airway pressure release ventilation. Sometimes if you want to understand the mode, you compare it with the existing mode. So APRV is nothing but a CPAP with intermittent pressure release. Nothing. It is a CPAP, continuous positive airway pressure with intermittent pressure release. You only intermittently release the pressure and you let the patient breathe spontaneously over those high pressures. That is APRV. It is little difficult to manage a patient on APRV, but this mode has been the only mode of the newer modes of ventilation which has been shown to have some use in patients with ARDS. Okay. What is the difference between BiPAP and APRV? See, BiPAP as a mode works at a peak inspiratory pressure, which is the IPAP, and then an expiratory pressure, that is the EPAP. And the patient usually breathes between IPAP and EPAP, but the normal inspiratory expiratory ratio is maintained, that is 1:1.5 to 1:3. So a patient spends a higher amount of time at the lower airway pressures rather than the higher airway pressures. That is the only different. It allows spontaneous breathing between two baseline pressures. That is the P inspiratory pressure and the PEEP. PEEP is the expiratory pressure and P inspiratory is the highest pressure. What is the difference with APRV? Difference with APRV is patient spends most of the time at low pressures. That is the expiratory pressure, because the inspiratory expiratory ratio is normal, which is 1:1.5 to 1:3 or 1:4, where you give more time to expiration than you give to inspiration. That is normal ventilatory mechanics. But airway pressure release ventilation, it works at two levels of CPAP. It works at two levels of CPAP. One is high, one is low. High is P high or P inspiratory, and low is P low or P. And this also has an added setting of T high and T low. How much time you want the patient to spend at a higher pressure and how much time you want to let the patient spend at a lower level. And usually the high time is more. Most of the time is spent here. And because the patient spends most of the time here, there is intermittent release which then puts the patient in low pressure. There is an inverse inspiratory to expiratory ratio, usually 2:1. usually 2:1. There is a inverse inspiratory to expiratory ratio that is usually 2:1. Okay. Now let's talk about APRV in detail. Let's talk about APRV in detail. See, APRV lets the patient breathe spontaneously at higher pressures, but it also gives mandatory breaths. So there is a mandatory inspiration that starts. Mandatory inspiration, which is usually time triggered. A mandatory inspiration that is usually time triggered. Patient is allowed to breathe spontaneously at both levels of pressure. Patient is allowed to breathe spontaneously at both the levels of pressure, the higher pressure and the lower pressure. If you talk about indications of APRV, then anywhere where you have a compliance problem, there APRV is a good mode of ventilation. So it's an alternative mode in patients with low lung compliance, like acute lung injury or ARDS, because it makes sure that there is low peak airway pressures than pressure support ventilation. Lower peak airway pressures with pressure support ventilation. Okay. Now let's talk about advantages of APRV. I told you APRV is again a short note, therefore we need to write these obvious advantages. ये inverse ratio ventilation के भी advantages हैं. There is recruitment of collapsed alveoli. See, anywhere where you do not allow the patient to exhale properly, the alveoli will be open and there will be recruitment. Increased aeration of dependent lung. Increased aeration of dependent lung, and it improves cardiac output, renal blood flow, glomerular filtration, it has an overall advantage of improving cardiac output, renal blood flow, glomerular filtration. So overall it is very good. Overall it is very good. But problem is, disadvantage is compliance problem. Patient compliance. You usually need to sedate the patient, because you give very less time for the patient for expiration. So there is stacking of breath. There is always a risk of auto PEEP. Risk kya? Auto PEEP is a feature of airway pressure release ventilation. Auto PEEP is a feature of APRV. It actually decreases the shunt. But auto PEEP will have cardiovascular effects. It will cause increase in intrathoracic pressure, which will decrease the cardiac output, and it can cause a lot of hemodynamic changes in the patient. Let's look at the airway pressure release ventilation, that is the APRV, and biphasic positive pressure. Now, if you look carefully, in APRV, you can see that the patient spends lot of time at higher pressures. The patient spends lot of time at higher pressures. Can you see? These are the spontaneous breath which are at higher pressures. So there is T high and T low, which is usually 4:1, and P low, and this is P high and T high. P high and T high. Spontaneous breath occur at any point without altering the ventilator delivered breaths. But if you look at bi-level positive airway pressure, then it spends very less time at higher pressures. So T high to T low is 1:124. So it is more spontaneous and it is more natural, physiological, but इसमें changes in the alveolar characteristic will keep on happening. Again, there will be expansion of the alveoli at higher pressure, and then there will be decrease in the volume of alveoli at lower pressures. But APRV में the volume of the alveoli keeps open because you spend higher time at higher pressures and lesser time at lower pressures. Okay. Another mode of ventilation. Achha, let's look at the advantages and disadvantages. The same thing which I have actually written. You achieve a high mean airway pressure with low peak pressure. That is the most important thing. High MP with low peak airway pressure, and peak airway pressure is responsible for the injury in ARDS. Maintain normal cyclical decrease in pleural pressure, allows inverse ratio ventilation and all the advantages of inverse ratio which we'll see. Augments venous return, increases cardiac index, reduces need for sedation, paralysis, improves renal perfusion, increases osmolar clearance, increase urine output, decreased basal atelectasis and may decrease tidal space, dead space, improve patient ventilator synchrony. Disadvantage is it's a pressure target mode with a variable tidal volume. CO2 elimination depends on spontaneous breath. Increase in airway resistance can hamper CO2 elimination. Increased work of breathing with asynchrony. Not useful in large bronchopleural fistula. Increased ICP. Auto PEEP is usually present and contraindicated in high expiratory resistant states like severe asthma, COPD. Okay, so these are the disadvantages of APRV. जितना याद हो गया. Otherwise, what we have written, the 3 points in advantages and the 2 points in disadvantages are more than sufficient. Let's talk about inverse ratio ventilation. Inverse ratio ventilation. So conventional ventilation has an inspiratory-expiratory ratio between 1:1.5 to 1:3. So you give higher time to expiration and lesser time to inspiration. Expiration is passive. Now, what is the concept? Concept is to increase the inspiratory time to improve oxygenation in ARDS. Increase inspiratory time to improve oxygenation in ARDS. So in inverse ratio ventilation, your inspiratory to expiratory ratio can be 2:1 to 4:1. With pressure controlled ventilation, that is the most important part. With pressure controlled ventilation, that the ventilation that the patient is giving is pressure control. So the target is the set pressure, but you spend a larger time in inspiration rather than expiration. How it improves physiology? Let's see it, how it improves oxygenation. Let's look at the physiology. This is what you have to reproduce in the exam. Physiology. So there are 3 ways in which it improves the physiology. Decreased intrapulmonary shunting, improved VQ mismatch, and decreased dead space ventilation. Decreased dead space ventilation. But the unique thing is that all these 3 things can be achieved with normal controlled mechanical ventilation with PEEP. So it is not something that is unique to inverse ratio ventilation. What is unique to IRV? What is unique to IRV is that it increases mean airway pressures. It increases the mean airway pressures, and it has a property of auto PEEP, both of which decreases the shunt, intrapulmonary shunt, which becomes an important factor in ARDS, the intrapulmonary shunts that have been developed. So that is unique to inverse ratio ventilation. But obviously it comes with adverse drug effects. It comes with certain adverse effects. The biggest adverse effect of such high inspiratory times would obviously be barotrauma. It also shifts the fluid. It shifts the exchange of fluid in the alveoli, and it actually worsens pulmonary edema. It worsens pulmonary edema, and the patients are agitated. So you need a lot of sedation. You need lot of sedation. So this is again a short note that comes, that is inverse ratio ventilation. The name is only telling you IRV, inverse ratio, where the ratio is inverse between inspiration to expiration. Inverse ratio ventilation. Okay. Now we will talk about two modes, NAVA and auto mode. And these are again theoretical modes. Auto mode, the name is only telling you auto mode is a completely controlled mode of ventilation. Again, a closed loop ventilation where the ventilator is interactive with the patient's need. So there is a breath by breath adjustment, and there are both again control and support mode. So it's a ventilator is interactive with patient's needs. So there is a breath by breath adjustment, and both control and support modes are used. That is auto mode. But the most exciting is this NAVA, which is a neural adjusted ventilatory assist. NAVA. Now let's try and understand. The initiation of the breath happens in the brain, central nervous system, which sends the signal to phrenic nerve, which causes diaphragmatic excitation, contraction, chest wall expansion, airway pressure, flow and volume. This is normal. Normally, the current technology is that we set the airway pressure, flow and volume, and we give this information to ventilator unit, which will then deliver the breath. तो नीचे से ऊपर जा रहा है. Futuristic technology would be, ideal technology would be where the impulse is initiated in the brain. You sense that only and change the breath characteristic. What we have done is we have intervened somewhere in between, where we have put a probe that will measure the electrical activity at the level of diaphragm and accordingly adjust the pressure that is given by the ventilator. So electrical activity of the diaphragm is captured fed to the ventilator and used to assist patient breathing. This causes synchronized breathing. This is NAVA, neurally adjusted ventilator assist. Normally what we do is we put a probe a NAVA probe in the esophagus, and that esophagus is near the diaphragm, lower end of esophagus, so it will sense the diaphragmatic electrical activity, and accordingly that probe goes into the ventilator to adjust. Again, it is not used very commonly, but yes, it is one of the newer modes of ventilation, right? So I told you that we are going to start with the discussion of newer modes of ventilation, and we divided them into intra-breath variations and inter-breath variations. We discussed PRVC and VSV first. Then we discussed adaptive support ventilation. We compared volume assured pressure support and proportional assist. We compared BiPAP and APRV. And in the end, we talked about auto mode and NAVA. So this completes our discussion of modes of ventilation that we want to discuss in this module. Now, next week, I'll probably take 2 sessions. I will finish off the weaning criteria, the weaning modes of ventilation, the criteria of weaning. We know how weaning is being done, but the criteria of weaning, and we'll try to include a short topic of ventilator graphics, and then we'll only be remaining with the sepsis and the sedation in the pharmacology in ICU, which again, with are very small topics which can be done a week after that, and will be done with the next module. So I'm going to soon take feedback from you regarding how you feel about this module and what are the things that you wanted and you liked it. And then accordingly, we can plan the next module of our resident course. So I hope you are attending these sessions, and I know most of you are not coming live, but that is fine. Ultimately, the idea is that you have got one session to be done per week, and I'm not bombarding with you with too much. It's like a slow and steady learning that we have to keep on doing. You keep on making notes. Unless and until you make your own notes, these things are not going to stick. And I don't want you to come back and buy the course again and again try to listen to these things. Listen it once, sit with me, make the notes. You have the annotated PDF that is uploaded. Go to that. If you have any doubt, you can ask me anytime on the group. So I hope this session is useful. It was a purely theoretical topic, but since we have done the basics of ventilator, the modes of ventilator in such great detail, therefore this becomes very, very easy. So if there are any doubts, do let me know. All the very best. Good night.